Chetan, Dr. Lakumar has joined.
Yeah. Good afternoon, Dr. Lakumar.
Good afternoon. Hi.
Hi. Your camera shutter is half closed or what?
Just give
Yeah.
a second.
Yeah,
Yeah,
okay,
no,
fine.
okay.
I thought shutter is half closed or what?
Okay.
Hi, how are you?
High five.
Just start sharing. Just check it out whether you can share it or not.
Yeah, just see.
Yeah. Bhaskar has not joined. Yeah, he is there.
No,
Hello.
yeah, let's see whether I
Hello.
can.
Yeah, please.
Good afternoon, sir. Good afternoon.
Good afternoon.
Dr.
afternoon.
Lakumar, Dr. Bhaskar Shanay here.
Yes. Hello.
Hello, nice to see you, sir.
Nice to see you. Yeah.
I am driving. I am in the car, so somehow I could not access the system. So I am joining through my mobile. Yeah.
Is it?
Yeah.
Right.
No,
Now I should
share it once.
just give
Then
me a
we will
seat.
have formal introduction and then we'll go ahead. Just check it out whether you can share it, you are able to share or not.
Screen. Just see. Join from Zoom. I need to select the.
Share. See, there will be share green button on the center. Either up.
Yeah. Okay.
Yeah. Okay. Fine.
Okay. Then.
This is your screen. Now you just show
Yeah.
your PPT where you kept it open.
Yeah, there it is. We
This
can see
is,
the slide.
You can see,
Yeah.
no?
Yeah. Just try and make it
Yes,
full
sir.
screen.
Yeah.
Try and make it full screen. Yeah. Great.
Great. I think it's 3:30, so we can start, right?
Hmm.
Just stop sharing for 2 minutes, sir.
Yeah, okay.
Good evening, friends. Welcome to yet another link of International Speaker Forum. This is a new initiative which has been started under the able leadership and chairmanship of Dr. Bhaskar Shenoy, sir. We know that certain diseases, we are having some common issues, particularly in our Southern East Asia's part. So we thought of going beyond the boundaries and let us discuss the certain diseases which are common to us. And in that, we had a wonderful webinar last time by Dr. Lucilam, and she did a wonderful job by just exploring everything about dengue. And now what we thought is something different. We can try it out, and that's what for which we are fortunate to have Dr. Lakumar with us. So I'll just formally introduce him, and then I'll hand over to first. I'll request Dr. Bhaskar Chana to welcome all of you. Then I'll introduce Dr. Lakumar. Dr. Bhaskar.
Thank you, Dr. Chetan. Good evening, all the viewers. Welcome, Dr. Lakumar. It's a pleasure to have you in our webinar. And I was with him in the Asia Dengue conference at Manila a few weeks back. And that is the time this idea came. And he has readily agreed. Any academic thing, he's always there. And it is nice to have his inputs, who is the pioneer, known as pioneer in the management of dengue. Especially in the Southeast Asian countries and across the globe also. And he has done a lot of work in clinical management of dengue. And the good thing is that they have been able to achieve zero dengue death in their country. And I think we should learn those good points from them and implement in our country. Having said that, this is a different kind of thing, second in the series of International Speaker Forum, wherein the ultrasound in dengue is a non-invasive method wherein they have been using it for clinical management, predicting the severity, and even I think they can make out the early signs of dengue and differentiate from other viral infection which mimic dengue. And they've been able to tell how the plasma leakage occurs and can we triage the dengue based on these things, and how we can correlate with the hematocrit. That's the most important thing, because we do most of the times with the hematocrit the progression and severity, but without that they have been able to do it with the ultrasound only. So all these points probably we need to learn from them and try to implement in our practice, so that we will be able to give a better quality of management to our patients. And we have none other than Dr. Vijay Vele as the moderator for that, who is a good friend of Dr. Lakkumar. Welcome, sir. Looking forward for a great discussion today. Thank you so much.
Yeah.
Thank you. Thank you, Dr. Bhaskar. A brief introduction of Dr. Lakkumar Fernando. He is from Sri Lanka. We all know that senior consultant pediatrician, founder of Clinical Head, Center for Clinical Management of Dengue, Hemorrhagic Fever, Negambo, Sri Lanka. He was outstanding Asian pediatric APA 2016. He's a member of IPS Infectious Disease Committee, and I was fortunate to share IS with him in dengue symposium at Mexico during the International Pediatric Association conference last time. And he's also a member of National Expert Committee of Dengue Sri Lanka, co-author of WHO CRO guideline on dengue 2011. So he's been, as we know, that author of many international publication presentation on dengue. So he will definitely going to justify and enlighten us about this particular topic. And then I'll request Dr. Dr. Vijay Ule, sir, who doesn't require any introduction to this August gathering. He'll be moderating, and we know that he has taught us dengue from ABCD to D for dengue to all of us. So welcome Dr. Vijay Ule, sir, as well as Dr. Lakkumar, sir.
Thank you.
Over to Dr. Vijay Ule, sir, for further proceedings.
Well, very good afternoon. Thank you, and welcome to my dear friend Dr. Lakkumar on the platform of Infectious Disease Academy of Pediatrics of Indian Academy of Pediatrics, and it's such a pleasure to have him. Uh, you have to see to believe what he has done in Sri Lanka. I've been there in 2015, spent a couple of days, and I've been interacting with him. And he is the person who is instrumental in bringing down the CFR in dengue to near zero. And all of us know that it is the prompt recognition and optimal fluid management which is the crux of management. I still remember his golden words and the golden triad. He always would say that the dengue one which leaks would leak only for 48 hours, and if you tide over these 48 hours, you are through. And the beauty is in early recognition of the time at which the leak begins, so that you can plan your management in the next 48 hours. So today, let us learn from him how best he has utilized different tools, one of them being ultrasound, in recognizing the beginning of the leaky phase, and how best we can optimize fluid therapy, and like their country, move towards zero dengue deaths in our country as well. He has huge experience, personal experience, and his center. He is the founder and member who has established this center, and has been a boon to Sri Lankan citizens. And with this few introductory words, let us hear from Dr. Lakkumar on optimal management of dengue and how best to utilize various tools in the management of dengue. Over to you, my dear friend, Dr. Lakkumar.
Thank you.
Yes, sir.
Yeah. Right. Hope you hear me.
Yes,
Yes.
yes.
And yeah.
Slides are visible. You are
So
very clear. Yeah.
yeah.
Yes, sir. Yes, sir.
Yeah. So I'm really going to talk about bedside ultrasound for zero mortality in dengue. And or this is also known as what you call focus or point of care ultrasound. I need to say that I'm only an expert in clinical management of dengue, but I'm not an expert on ultrasound, not even in limited ultrasound. I'm going to talk about topic, though I'm not technically competent in doing ultrasound. Purposely, I decided not to learn how to do. I'll tell in my mission to sort of propagate this. But I've witnessed thousands of ultrasounds being done on dengue patients and seen the reports and pictures almost daily for the past 13 years. Sorry about the slides not moving. Just wait.
You can click on the slide, I think, sir.
Yeah, I think that's what I should do. Yeah. So this is my center. I mean, as I always say that we look after patients from 2-day-old to the 100-year-old, and in my center, people who have come to us with a platelet count of more than 100,000 maintain zero mortality since July 2013. And we've used the same fluid regime and same management principles in the private sector with zero mortality. I think zero mortality of dengue can be achieved through these 7 steps. But today I'm going to talk only of the second step of what we call routine bedside limited ultrasound to identify leaking early. You know, the dengue has 2 classifications, 1997 classification, which was modified in 2011, which I also had the ability to contribute, where dengue is divided into dengue fever and dengue hemorrhagic fever. In the patients who have dengue hemorrhagic fever, those who have compensated, those who will leak but will not go into shock is DHF grade 1 and 2. Grade 3 and 4 are the dengue shock syndrome, where you have plasma leakage that compromises their pulse pressure. Then 2009, there was this other classification by the 2009 group. You said Lucy Lum did your previous talk. She was the main author of this 2009 guideline, where dengue was classified into probable dengue with warning signs and severe dengue. But whenever you look at dengue mortality, that we know that 95% of the dengue deaths occur in the DHF group or the patients who start leaking. So managing leaking patients better is the best way to reduce dengue deaths. And if you look at these 2 classifications, the severe dengue of 2009 classification is mostly the dengue hemorrhagic fever after 1997. So natural dengue is generally a 7-day illness where some start leaking, usually after day 3, commonly on day 5, but rarely even day 2, and sometimes even as late as day 7. Usually, this happens when the platelet count is below 100,000, but rarely it can happen when the platelet count is above 100,000 and dropping. So this is the main part of the natural course of the dengue hemorrhagic fever. You have the febrile phase, critical phase, and the convalescent phase. The critical phase is the period that there is leaking, and if you have no leaking, you are a DEF, you are called dengue fever without leaking. But when you look at the timing of the onset of the critical phase, you will see that the platelet count will start dropping during the febrile phase along with the white cell count. But once the febrile phase is over, the white cell count will start rising as the bone marrow suppression is less, but the platelet will also start producing more platelets, but they will be consumed during the leaking period, which is gone by the cytokines. And then when you see the platelet count, when the critical phase is over or the leaking phase is over, you will see that the platelet consumption stops and the platelets start rising. So if you really look at a patient whose counts are followed, when the platelet counts start rising, definite rise, say 2 consecutive platelet counts rising, and if it without a laboratory error, then you can be almost 99% sure that the leaking has stopped, irrespective of what you see on the ultrasound, irrespective of what you think that the patient may be leaking. So leaking may be as short as 6 hours or as long as 48 hours. Whenever the hemodynamic status, we should remember, even though the patient's hemodynamic status is different, we really need to think that 99.9% of the time when the platelet count start rising, that the leaking period is over. So that is something to be remembered, because I'm going to talk about ultrasound, which is useful in diagnosing the onset of leaking. But what is to know the end of leaking, the best is to go by the rising platelet count. So the seromortality of dengue, you have to be sort of proactive than reactive. One of the main reasons why we lose patients is that we don't prepare early. So we have to eliminate shock and reshock. And so the onset of leaking has to be identified through bedside ultrasound, and the end of leaking through definite rise of the platelet count. Fluid therapy, the importance of identifying this leaking period properly is that the fluid therapy is different in patients who leak and who do not leak. So DHF, the leaking syndrome, is there is a transient plasma leakage through capillary walls only in the pleural and the peritoneal cavities for a period of not more than 48 hours. The volume loss in the intravascular compartment can lead to shock and organ hyperperfusion. This is what happens in dengue. The most fascinating thing about the leaking of dengue is that this leak has a stereotypic pattern, and the leaking starts around the gallbladder, then get into the Morrison's pouch, or the potential space between the right kidney and the liver. That is called the Morrison's pouch or the hepatorenal pouch. Then get into the pelvis, then to the peritoneum, and then to right pleural effusion, and last to left pleural effusion. There is a pattern. This pattern is nearly always so. The reason for this sequence is not fully understood. But maybe the right lung has 3 lobes and larger pleural space, so the fluid may be leaking to the right lung before the left. Right. So once the leaking is over, the fluid reabsorption also follow the same pattern, not the reverse, same pattern. That is, fluid will first disappear from the gallbladder, and then from the Morrison's pouch, pelvis, peritoneum, right pleural effusion, and the last to disappear is from the left pleural effusion. If you see a patient who has body swelling, pericardial effusions, periorbital puffiness, and fluid elsewhere, they are all due to giving excess of fluid. So natural leaking does not have fluids elsewhere. And large majority of dengue deaths occur inside the DHF, as I said at the beginning, and managing DHF is the best way to reduce dengue. And dengue hemorrhagic fever is not badly managed DF. For some reason, some patients leak. But dengue shock syndrome is badly managed. Dengue shock syndrome is grade 3 and 4, which is often badly managed grade 1 and 2. So when leaking is detected or suspected, fluid therapy needs to be changed. So leaking is DHF. If you give more fluid, there will be more leaking and overload. If you give less fluid, there will be less leaking. So that's the way we can control leaking. But if you give too little fluid, then the patient will go into shock. Still, there are no good predictors to suggest who will leak before it happens. And so if you are aiming for zero mortality, differentiating DF from DHF as early as possible is the most important. Can the warning signs do it? The 2009 guideline is famous for its these warning signs, but these are not perfect. One of the things that I want to know is that clinical fluid accumulation is a warning sign. By the time you see fluid accumulated enough to be detected clinically, it's far too gone. It's not qualifying to be a warning sign. Of course, if you have a patient who is, when you review dengue deaths and all, you will see that tachycardia is an important warning sign. When the patient's heart rate, when the fever is not accounted to the heart rate going up. But surprisingly, in this 2009 classification, tachycardia is not a warning sign, but clinical fluid accumulation is a warning. So it is not perfect to detect. This is one of our publications at the ICIDE. And we looked at the sensitivity of the ultrasound in versus warning signs. We found that 64% of the leaking patients did not have any warning signs described in the 2009 guidelines. This was 400 DHF patients, consecutive DHF patients who were admitted to our unit during the 2017 epidemic. But again, when you really look at the 20% rise of the baseline that is prescribed in the 1997 guidelines, still 96% of the leaking patients did not have hematocrit rising to more than 20%. Also, in the when you look at the PCVs. So actually, the 2011 guidelines, this 20% was reduced to 10%, and we said PCV rising towards 20%. So PCV alone is not good for diagnosis of DHF if you are aiming for zero mortality. But if you are in a setup where there is no facility to do bedside ultrasound, then that's all right to do it, but it's not good enough if you are aiming for zero mortality. However, bedside capillary PCV is essential for perfect fluid therapy. So you should have the bedside capillary PCV machine with you if you are aiming for zero mortality. So objectively diagnosing DHF currently, limited ultrasound scanning of the chest and abdomen is the most objective way to diagnose DHF in the clinical setting. And routine ultrasound is now standard in Sri Lanka's dengue management. So when routine bedside ultrasound is possible, I don't think we should waste time with warning signs. They're not needed to detect severe dengue. Why play in the dark? This is 2025, and seeing is believing. So what we are talking about ultrasound is, now before the ultrasound came in, of course, we had patients whom we were blind treating, and as a result, they were given fluid without knowing what we are doing, and we had large effusions which are not seen now. And this is another patient who came in shock. And those days we had to take the patient to do a lateral decubitus to see fluid accumulation. I learned dengue from Thailand, and this is what we learned. So we had to take the patient to do a lateral decubitus chest X-ray to do the ultrasound. Of course, fortunately, I need to tell my story about starting routine ultrasound. Everybody probably knew. Everybody probably knew that you can do detect ultrasonically, but whether this is practical in the normal setting was the question. Just give me a second. And I was fortunate that when in the hospital that I worked, the Negombo General Hospital, I had a great radiologist who was very, very helpful and friendly. And because it was not so easy to send patients to do just X-rays, lateral decubitors when we were thinking of leaking. We could send to him for ultrasound, and he started doing ultrasounds for us. And after a while, I should mention his name, Dr. Prasanna Jayasekara, and he helped. And through those ultrasounds, I learned. Through those ultrasounds, I learned how to do. Through those ultrasounds, I'm sorry, I need to tell the person who is calling me not to call. Just give me a second. Right. So after this, I asked him whether he could help me by training our doctors to do the ultrasound so that we don't have to send the patient to his department. And I was trying to get the scanner, but unfortunately he told me that he does not know whether, as a radiologist, whether he's permitted to treat ordinary doctors to do ultrasound. Of course, I understood his position. And I also, at that time, I decided that I should never learn to do ultrasound, and I'll be going to somebody else's territory, and that might prevent me from propagating this very fascinating way of detecting leak in patients. So I had to get down an ultrasonographer from India to train the first doctor that I got for my unit. And this was on the 11th of October that we had a training session for my doctors, who kept on training the others. And of course, this was 2012, and we gradually propagated it. Mostly, initially, people thought that it's not practical. But in the 2000s, by the time we had the 2017 epidemic, where we had almost 200,000 cases, nearly all patients who had their platelets dropped below 100,000 had ultrasound chest and abdomen in the country. So this was you need only half a day's training and bedside ultrasound. This is a post intern doing bedside ultrasound, and our radiologists were so good that they even came to our unit to do ultrasounds in difficult cases. And this was in 2017 that when we did large number of all the patients who qualified to be potential leakers with a platelet count of less than 100,000 or so gathered, because they didn't, at that time we did not have many scanners. I had two ultrasound scanners in my center, and so we first presented our findings in an international research or experiment conference in Bangkok, where we showed 80 serologically confirmed patients, where we showed this, that 98% of those with leaking had their gallbladder thickness, and few had bilateral pleural effusions, and this was what we presented. And this is the way fluid accumulates in this pattern. I would go through this fast, and that was selected the best paper in that conference. Then we again published our findings at the ICID conference in 2019, and this is our data in the 2015 to 2023, and as you may see that out of say 3,000 DHF patients, this is the total number of scans we've done, and pleural effusions were detected in 58%, and fluid in the pelvis in 78%, pericholecystic fluid, pericholecystic thickening in 88% of those DHF, and so that's the way it progressed. And when you really look at when did these patients start leaking, majority started leaking on around day 5, occasional patient on day 2 and day 7. Right. So I say that the limited ultrasound scan, Sri Lanka is not as rich as India, or I mean, it is whether it is doable. It's only limited ultrasound scan. You don't really have to. One of the biggest worries that people had was that when you have to do the ultrasound scan, whether the radiologists, mostly they thought that if they miss a tumor or something else, that they will be later blamed. So we developed this, what you call the limited ultrasound scan, because we know there is a pattern. We know that there are these fluid accumulate only in few places in the natural leaking, unless you are fluid overloaded. Therefore, all what you need to do is to look at it. So it is only limited ultrasound scan and leaking follow pattern. And so all what you need to do is, say if a patient comes on day 3 or so, you know that the leaking will start from the gallbladder. If there are no fluid in around the gallbladder, and there's nothing in the hepatorenal pouch, then you don't have to really look at the other places. You don't have to look at the pleura. You don't have to go elsewhere if the patient comes early, because we know that and the leaking starts there. So it's a procedure that can be done faster than a full blood count. Faster, it takes only, I mean, in our setup, where patients are, where doctors are quite familiar in doing it. Now it's a 5 minutes procedure. It's objective. If somebody says that I see leaking, another person can always check and see whether that is correct or not. And then there is no exhaustive training needed, as I said, and leaking sand takes only a few minutes, and it's faster than any blood test. There are no reagents needed, and you only need the jelly. That's extremely cheap test to do, cheaper than any blood test, and we can keep repeating at no cost. So if you think, if you are not able to do this, all what I say is that you have to get the system organized to make limited bedside ultrasound routine and standard. That will save a lot of money done from various other tests. And this is, we had a training for the group from senior consultants and some pediatric intensivists from Philippines in April and late April to May in our center, and this is them learning, doing ultrasound scanning at our center. So when to do the ultrasound? When should you start doing the ultrasound? We should really start doing the ultrasound when the platelet count is dropping towards and beyond 100,000. Also when there is a very rapid drop in the platelet count. So very occasionally, with platelets more than 100,000, when the patients have signs of hemodynamic instability also, or if there is unexpected tachycardia, you will have to still do a. So whenever a dengue patient, the diagnosed dengue patient who is managed as for dengue becomes unstable, it's best to do an ultrasound. But you will need to keep it repeating to see whether there is once you detect, you need to confirm there is progression by doing a repeat scan. Right. So when should you do the ultrasound scan? In the random sample of 500 DHF cases in 2017 epidemic, we found that one out of the 500 leaked at platelets around 200,000. There were 3 who leaked between 120 to 100, and the 99% leaked when the platelet counts are below 100,000. So 100,000 is a good mark. When there is clinical deterioration, when there is tachycardia, narrow pulse, faintness, dizziness, increased thirst, reduced urine output, we should again do ultrasound. And if the ultrasound does not show leaking in a patient who is unstable, we think that patient is a leaker. But when you do the ultrasound, you see that there is no leaking. So you have to think of other possibilities. If it is already a diagnosed dengue, we have to think of bleeding, concealed bleeding, but may start treating as for leak. You can always start treating as for leaking, but if repeated ultrasound show no leaking, think of alternative diagnosis. Stop doing fluids as for leaking if there is no ultrasound evidence of leaking. So if not serologically confirmed dengue, think of an alternative diagnosis like sepsis. It is important to keep in mind the time of ultrasound that we do. Sometimes the patient's platelet count is 150 at 6 a.m. By the time we get the patient, maybe the platelet is 10 a.m., the platelet count may have dropped. So only a platelet count repeated immediately after the ultrasound could suggest exactly at what count the patient started leaking. But remember, though there is an entity called concealed bleeding, it is a well-known thing because we may have clinical features suggestive of bleeding, but we cannot exactly find where the patient is bleeding from. But there is no entity called concealed leaking in dengue. So in this area of bedside ultrasound, so there is nothing called concealed leaking. If you cannot see leaking in those spaces, the patient is not leaking. So natural fluid leaking follow a pattern as I told you, and this is the chart. This is what you call the ultrasound form that we developed, which is now this was developed by me, and then this is now adopted as the document in the country. And just to see the gallbladder edema, pericholecystic fluid, hepatorenal fluid, pelvic fluid, right pleural effusion, left pleural effusion, and just tell whether it is present or absent. That is why this limited scan takes only 5 minutes. And tell how much fluid you see. Then when you repeat, you can see whether it is going up or not. So, so if there is fluid accumulation detected in any other spaces, these places suggest fluid overload. Also remember that in a dehydrated or fluid deprived patient, even though leaking start due to the onset of leaking started due to the onset of capillary permeability, the amount of fluid detected in the expected phases could be minimal because the patient's hydration is not good. But so when you give but with hydration, the fluid becomes more easily detectable. One of the things that you could do is if you have a patient whom you cannot see much fluid, or you're not sure, but you think that the patient is a confirmed dengue, and you have serological, and you think this is very much a dengue patient. One of the things you can do is you can give the patient a fluid bolus, and then repeat the scan after a while and see whether when the patients correct the hydration, and if then you may be able to easily detect the leaking. So once leaking is over, the reabsorption, as I said, is also happening in the same pattern. But if a patient presents late, suppose a patient comes on day 6 or 7 with very low platelet counts, and you see that it is like that the patient is coming with a definite history, we know what the onset is. This may be the late, the patient may be coming late. I mean, remember some of our DH patients may be leaking at home without any problem, and they may be going through their critical phase and recovering without any problem, and sometimes coming to hospital and staying at home. Mild leakers can leak at home and recover. So if they come late with very low platelet counts, if this clinical suggestive of late and possible DHF, don't just do only the gallbladder and wall and the hepatorenal pouch and pelvis, and when there is no fluid, say that this is not a leaker, because maybe that he's the fluid from those, because he's late, he's already finished his 48 hours or towards the end of his 48 hours. Maybe after the 48 hours, or his leaking period is over. So the fluid may have got reabsorbed, and this is past the leaking phase. Still, some fluid may be remaining in the left pleura. So look at the left pleura also in those patients. This is how the scan will show when there is no fluid. So once leaking is detected on ultrasound and gradual progression from one space to the other in the sequence is noted, the best way to conclude leaking is over is not through ultrasound finding, but the definite rise in the platelet count, as I told in the beginning, and also the improvements in clinical well-being. So the way to detect onset is through ultrasound, but the way to detect the end is uh, through the rising platelet count and the clinical well-being. So even after leaking stops, remember fluid levels in the especially in the pleural effusion or in the ascites, your fluid levels may go up for a while, even after the leaking period is over. Just because the pleural effusion was 3 centimeters yesterday morning, but the 48 hours is over, and now you see it is 5 centimeters, don't think this patient is leaking for 60 hours. Because like the flood levels go up even after the rain stops, that you can have accumulated fluid levels increasing even after the leaking stops. So effusions will remain, once you have effusions, they will remain so before they start reducing for about 12 to 18 hours. And that is the equilibrium phase. And during this period, because there are fluids, don't give these patients colloids or volume expanders. If you give this patient dextran or volume expander, and in any time the fluid may start regressing, and then the patient can go into heart failure. So if ultrasound is negative in a patient whom you are following for leaking, this is a diagnosed dengue with dropping platelets. If the ultrasound is negative, either this patient is a DF, a patient who is not going to leak, dengue fever, or a DHF who has not started leaking yet. There was an article in the Lancet in 2020 where they said they thought whether this could be used for triage. Of course, you may be able to use ultrasound for triage to send patients to a high dependency for better monitoring inside the hospital. But I don't recommend to send a patient who is ultrasoundically negative home, right? Home. This is the article that appeared in the Lancet, and it was Scott Halstead. He replied. This was published in the Lancet, saying that it is not exactly the best thing to do. So should ultrasound be used as triage? No, it's not the best to decide on hospital admission. So if a potential leaker, it is best to admit the patients when the platelet is less than 100,000, or when there is a rapid platelet drop even above 100,000, or if the patient is hemodynamically unstable. So diagnosing DHF, the fluid leaking is selective to pleural and peritoneal cavities. Gradual accumulation of fluid in these spaces shown in limited ultrasound scan done serially in suspected cases is the most objective way to prove continued bleeding. If you see non-progressing fluid, you have some gallbladder wall thickness, some fluid in the molluscous pouch or pelvis, which is not progressing. Sometimes some pleural fluid or some peritoneal fluid, don't consider this as leaking. They're not progressing. You don't have to treat them, manage them as, or you don't have a fluid therapy as for leaking. Then if fluid leaking is selective, right. So in a, I think I said this also before. With improved technique of identification, minor leakage will become easily apparent. Gallbladder wall thickening and fluid ascites, pleural effusion, pericardial effusion, hepatomegaly signs of plasma leakage. But physical examination cannot detect small effusions, the pleura or the peritoneum, hepatorenal pouch, gallbladder wall edema. So don't think that you can clinically detect bleeding, and I don't think doing percussions to find out whether there is fluid is a good thing in this year, in this time where our target is to have zero death. With improved technique of identification, minor leakage will become easily apparent. Right, let me tell a little bit about something that I don't know much about, but taking from my doctors who are learning from my doctors who are doing the scans every day. Gallbladder wall thickness, you have to have the patient supine. The normal gallbladder wall thickness is not more than 3 millimeters. It can be assessed by measuring longitudinal and transverse diameters. Take history about cholecystectomy. Somebody who has had a cholecystectomy may not, you will not see. If you see uniform thickness versus honeycomb thickness, our doctors say that if you have honeycomb thickness, they're associated with more severe leaking than or they are more rapid, more severe leakers. If there is only localized thickening, then repeat the scan after a couple of hours to see whether it will become uniform. Then it suggests that this patient is going to leak. Normally, the timing of early onset of leaking is just about maybe 2 hours or so. We can say if you see only gallbladder wall thickness, probably the leaking would have started maybe 2 to 4 hours before. Then if you see fluid in the hepatorenal space is a potential space. You don't normally see this space unless fluid come into this space. That's the potential space. Then we see fluid in that place normally. I mean, this is about 4 to 6 hours, but these are variable because there can be some patients who leak very fast, and these timings can be changed. This is a general thing about when so it's between the right kidney and the liver, and then ascites defined as abnormal amount of intraperitoneal fluid. The large amount of ascites can present with abdominal distension, nausea, vomiting, and dyspnea. Detection on plain X-ray requires at least 500 ml. And for you to develop abdominal pain, distension, nausea, vomiting, the warning signs, they're not warning. You have to have a lot of fluid in the abdomen. None of our patients will have these signs of nausea, vomiting with our fluid therapy these days. So as little as 100 ml of fluid in the peritoneum can be identified through ultrasound. If you see this kind of fluid, you can think that the leaking has gone on for maybe more than 10 to 12 hours. Then pleural fluid, abnormal accumulation of fluid within the pleural space. The normal radiograph needs more than 50 ml of fluid to detect it. That is, if you do it on a lateral decubitous. Ultrasound allows the detection of small amount of as small as 3 to 5 ml, but definitely It can reliably detect effusions as small as 20 ml in the clinical setting. It viewed in a coronal plane at the mid to posterior axillary line, right-sided, more common than bilateral or left-sided. If bilateral, left side 3 years later, if you see these pleural effusions, you can think that the leaking has gone on for 18 to 24 hours, even whatever the timing that you have decided on the platelet count in the clinical history. Think that the patient may have leaked at least for 18 hours if you see this. What about looking at the IVC? This is a question we were tried to do, looked at it, got feedbacks. My recommendation is if you are managing dengue patients with leaking and you have what you call point of care ultrasound, don't look at the IVC. I ban our doctors in our unit from looking at the IVC. Do not look at the IVC as part of a routine because bedside ultrasound meeting, it can be very misleading, may lead to wrong fluid therapy. Somebody will come and suggest to a decision that the IVC is flat, that patient should be given fluid. But I mean, in my previous talks, I was told about what you call what's volume over time scale to decide how much fluid that you can give. All this surpassing everything, somebody will say that you should give fluid, then it can be very dangerous. And once you have this information, it's very difficult not to act on it. So my recommendation is not to look at the IVC. I'll just show you very quickly a couple of case histories. This is a 5-month-old baby who presented with a platelet count of 700,000 and then with a neutrophil leukocytosis initially 700,000 plus, and 2 days later, so he was just fever. They thought it's a viral, it's a fever with bacterial sepsis, possible UTI, and urine culture was given some antibiotics and sent home. But the day after he came, where you see the platelet count has dropped to 230,000, which is still normal, and the neutrophil lymphocyte has reversed. There are more lymphocytes now after just this was 29th to 31st, and then the next day his platelet count had dropped to 78,000, 75,000, and then he was admitted to our center. This was 2014. And he had the leaking, but with progress ended up with pleural effusion and free fluids in the abdomen. NS1 done on day 5 was positive. Platelet count later dropped to 5,000. The 700,000 dropped to 5,000 by day 5, right? So remember that one of the key things that this patient would have been admitted when there was a big drop from 700,000 to 200,000, and probably leaking could have started soon after. And his IgM was positive on day 9. The IgG was negative, which suggests that it was a primary dengue. And this patient was a 5-month-old baby who developed leaking due to primary dengue. And actually, no mother's IgG also coming. So this is a primary dengue developing DHF. This was another 6-month baby. This patient came to hospital with a history of day 3 fever and a seizure and a respiratory arrest, circulatory collapse. There was no pulse, no recordable blood pressure, and the platelet count was 6,000, and the first SGOT-SGPT was 5,900, and the pH was 7. When I was told, I thought this patient is the chances of survival are very low. But when we did the ultrasound, we found that this patient had bilateral pleural effusions and also ascites. Though the history is only 3 days, I concluded this patient is a leaker who has finished leaking also, though it is still day 3. And due to the shock that produce leaking in an infant, where the leaking can be very short. Sometimes a 6-month-old baby the entire leaking period may be 6 to 12 hours. Maybe during the 6 to 12 hours, everything has happened, And so I considered, though this is day 3, this patient's leaking is over, and we didn't have an ICU bed. We used an improvised ventilator, because the baby was 8 kilos, and then we used a ventilator which was out of order due to some defects. Then we had to get a intraosseous line initially, and there was no respiration. So he had liver failure, renal failure, and also respiratory failure, and circulatory collapse. And this is the patient we took him to the PBU. Actually, this was a time where I managed this patient throughout. I was unwell, and I had to manage this by sort of keeping up through video calls and over the phone. And this is this one's SCOT went up to 14,000. The INR was 2, and creatinine was 1.48 for a 6 months baby, which we managed. Of course, there is no guideline for this kind of patient. This needs a lot of. I use my experience to handle this patient whose pH was 7.5, bicarbonate was 5.9, and lactate which went up to 11, and so on. And we use all kinds of fluid regimes, several blood transfusions, and so on. Even the patient then we got a femoral line, and they say that if you have this kind of 3-organ failure, including respiratory failure, the survival was a miracle. Of course, the baby survived, and but the baby was 96 hours later after admission. There was dengue virus 2 in the PCR, and NS1 remained positive from the day 1 to about day 9. IgG rapid first appeared on day 4. IgM became positive on day 7. So that's this is another case history that I want to show. This boy started leaking with a platelet count of 212, and it went on, and he finished his leaking, and the platelet count started going up without ever touching the 100,000 mark. So this can occasionally happen, and it is we can see the way I've shown how pericholecystic fluid was noted when the platelet count was 212,000, and pelvic fluid, right pleural effusion. He didn't have left pleural effusion, but then he's a DHF. He was very much otherwise hemodynamically stable, but we showed the fluid accumulation in the pattern. I got what you call this was him. So thank you. I think I'll stop here and giving you time for questions.
Dr. Lakkumar, that was a wonderful account of the utility of ultrasound, bedside ultrasound. And I mean, these are really pearls of wisdom and golden, tips that leakage by and large is only for 48 hours. You recognize beginning of leakage by ultrasound, but recognize stoppage of leakage by rising platelet count. These are some things which we have learned from him, and it's good. Can you please stop sharing the screen, Dr.
Yeah.
Lakkumar? Yeah. And with his huge experience, he said the pattern or stereotypy that the leakage follows. I have a couple of questions before we look at the questions in the chat box, Chetan. Like you mentioned that a little fluid in the Morrison's pouch does not necessarily mean that it is a leaky phase of dengue. However, at the same time, we may also made a statement that in a patient of dengue, ultrasound is the best way to diagnose the beginning of leaky phase, and it is the Morrison's pouch which gets filled up first. So how do you differentiate the two?
Actually
So does it
speaking,
require serial sonography to confirm?
yes. Actually speaking, when you have to give the benefit of the doubt, that when you see a patient whom you see from the time you see gallbladder wall thickness, then fluid around the gallbladder,
Hmm.
next fluid in the Morrison's pouch. When we see these things, we really need to think this is we have to immediately think, okay, this patient may have started leaking say 2 hours before or 4 hours before, and get the timing and
Hmm.
start the fluid therapy. I
Hmm.
recommend to use a certain fluid quota to be given you during the leaking phase,
Hmm.
and use the fluid quota and give your fluid regime. What I recommend is to give only 1.5 ml of fluid with intermittent boluses. Whatever that your unit has in your fluid protocol, start the fluid
Hmm.
regime as for a leaking patient. But after once you decide on the time, when you do repeat scans, if you don't see the progression, suppose the fluid is there in the Morrison's pouch, it's not progressing for all practical purposes. Maybe that is it's a mild leaker who has stopped leaking. We don't, the biological disease, there can be variations. But for clinical management of this patient's management cannot be any different to managing a DF or a non-leaker. Therefore, we have to label this one as a non-leaker, or manage this patient as a dengue fever and not dengue hemorrhagic fever. That's what I say. So that is for all practical or clinical management purposes. This is a DF. But
Yeah.
as you say, it may be a mild short leaker.
Yeah. The point of care ultrasound has been, it's being increasingly used in clinical management of various conditions. And to begin with, our intensive started using it for checking the fluid status, circulatory fluid status, collapsing IVC or full IVC. And of course, you made a statement that it can be a little tricky in dengue,
Yeah.
DHF. And then the fluid in the pleural space, pneumonia, bedside sonography is coming up in a big way, though it's an operator dependent modality. It's a tool worth working further on so that it becomes a standard of care in due course of time. Uh, the issue that we face in India is most of the small hospitals do not have sonography machine because we are governed by the PCPNDT Act. It's a big problem here. So maintaining records and submitting, even if you are not doing obstetric sonography, it's a big hassle and headache. Of course, most of the intensive units do have sonography machine, and intensivists do look at the especially in shock patients at the IVC and the contractility of the myocardium. But these are a few limitations. What is the scenario in your country? Are you governed by the PCPNDT Act, or it's not
I really
so
don't
strict?
know, but all I will tell that this, the ultrasound was initially used for like mostly the obstetric as well as the other the entities.
Yeah,
And in
yeah.
2012, 2013, I managed to get down two ultrasounds by asking our dengue control unit. My friend, the director dengue control unit, when he was convinced, he bought two ultrasonography machines, and he gave one to me and another one to the another center. Fortunately for me, the other center refused to have it, thinking that it is not practical. And then I was lucky enough to have both the scan machines. And then we started doing a lot of ultrasound. We learned more about it while doing it. And the most important thing is that it is a very good investment, because these machines last for decades if they are managed each other well properly.
Well, yeah.
And they don't have to be the most sophisticated ultrasound machines. They can be the most crude, the simplest machines, because just fluid is black, and all what you can see informer is to see whether there is fluid accumulation. So they
That
need
was
not be
my
high definition ones. I
yeah. That was
recently
my
bought a
next way. Yeah,
yeah,
that
I
was my
recently
next
bought a
question.
handheld, relatively cheap machine, which is as good as, which can be connected to the phone.
Okay, yeah. So, I mean, many of us do call for portable sonography, and that machine you say is good enough to pick up leak in dengue. It
Yeah.
need not be high definition sonography
Yeah.
machine. Fine. So, I mean, that is all from my end. Chetan, I turn it over to
Yeah,
you. Look
sir,
at the
wanted
questions
to
of in
ask,
YouTube, and yeah.
yeah, you said basically first you pick up is when you see the fluid around the gallbladder, right? Leaky phase. So you should be very careful in all the dengue fever cases because we never know, we can't predict which one will go for this leaky phase. Now, yes, you told that platelets you have to monitor. Okay, usually now in routine case management, we don't give much importance to platelet. But as you said, rather highlighted the importance of platelet in particular leaky phase. And that too, when platelet size start rising, that means the leaky phase is over. Now, what I want to ask is, in clinical practice, without going for much investigation, without going for sonography, can we use some clinical symptomatology to trigger that now it is a time for you to go for platelet as well as sonography point of care test? Is it something like whatever we have the severe dengue symptomology with warning signs? Can we take it? And now, which one is the most sensitive symptom?
Now, actually speaking, as I told you, unlike other diseases like cholera, malaria, anything, we don't see dengue deaths, home dengue deaths very much, or hardly any. And most patients only die in hospital. I would say they die in hospital. One of the reasons why they in hospital, they may be dying as a result of coming to hospital due to the management. So patients may be undergoing period of leaking in dengue, with them having thirst and other symptoms, and they are well enough to go drink more water, and then keep tied over their leaking phase by themselves, and then recovering of leaking at home. So there are no such symptoms as such. Actually, symptoms will develop if you start giving fluid. Then if you give a lot of fluid, that will increase the leaking. Then you will go into shock. Then if you give more fluid, you will go into what you call reshock. This phenomenon of reshock, which a lot of people describe, is never there in our center, and I think it's a iatrogenic thing. It's not reshock is not a natural phenomenon. It's a man-made thing. So likewise, there is no because if you want zero mortality, if you want some, if we think that the dengue can be a zero mortality disease, near zero mortality disease at least. So therefore, for that you need an ultrasound scanner. It's a very cost effective compared to many other things, many other tests and many other things that you really need to do.
Then is it worth doing in each and every case of dengue fever? What I am asking is which is the symptomatology which will guide me to go
So
for
when
this?
I think from the if you diagnose dengue, I think the best way to
Mhm.
diagnose dengue possibly now is that is another thing. I mean, I told you seven things. Is
Yes.
if you are living in a dengue endemic area, and if you want zero mortality, when you have fever, documented fever, you have to use a thermometer to see whether there is fever. If you have more than 38 temperature, and at the end of the first 24 hours, you should do a dengue NS1 antigen rapid test. There are very good
Yes.
sensitive tests where that will pick up. You make a serological diagnosis of dengue in 95 plus cases. There are no other infectious disease that you can have so accurate diagnosis
Agreed.
so early in
Agreed.
medicine, right? So you have this, you know this one is dengue. And then if you want seromegaly, you should do another platelet count the next day also. You have to do at least one platelet count every day. When you see your platelet count is either dropping fast from 400,000 to 200,000, or that is it's a big drop, or if your platelet count is now going below 100,000, then you should do your first scan. And all what you need to do is have a look at the gallbladder area and around that. And if there are no fluid, probably this you don't have to do the rest, and you can just proceed and then repeat the scan the next day. And if the patient becomes hemodynamically unstable, or patient becomes thirsty, the urine output drops, become faintish, then maybe the leaking has started, then you have to go and do a scan again. That's the way.
Correct. So the
Chetan, any other
IVC,
questions?
we don't have to see that. That means what
Don't
is.
have a look at the IVC. I mean, if I want to, I would say two things. During your critical phase and until the dengue is over, don't take to a cardiologist. Don't do echo. Don't do unless you have already messed. Because for natural disease, none of these are needed. Or of course, if somebody has fluid overloaded and given 3 times the fluid that the patient will need, then of course cardiologist and everybody will help is needed. And ideally, dengue patient need not be sent to the ICU also. So I would not get a echo and done during the 7 days of dengue, and once it is over, I'll definitely get the help of those colleagues.
Dr. Kulkarni is asking, okay, what is your experience about leak risk markers like CRP, platelet counts, SGOT?
None. None of the, unfortunately, that I'm involved in the study with an international study where we are trying to see biomarkers. Unfortunately, there are no biomarkers as such. If you have right hypochondrial tenderness, you probably your chances of leaking is high. And if you have a maculopapular rash, maybe you are probably at the early part of your illness, you probably are unlikely to be DHF. Those are sort of probably little things, but still there's no good biomarker or a study or a test that will suggest leaking.
Great. I think there are no further questions. I'll just look at the YouTube. Dr. Evle, sir, you can conclude.
Yeah, so it was really a very lucid and a very practical talk, and we have been at least I have listened to him several times, and every time I hear him talk, I learn at least one new point. And it's been really wonderful listening to Dr. Kumar. I mean, three gadgets that he has in his unit: a good multi-para monitor, a centrifuge, a card test, triple card test, and a sonography machine. And then you have patients from neonate to 100-year-old, and the zero death. Hats off to Dr. Lakumar for revolutionizing the fluid management of dengue patients. Thank you so much. I once again, on behalf of the Indian Academy of Pediatric Infectious Disease chapter, place on record our sincere gratitude and thank you to you. And I hand it over to Bhaskar to, say thank you finally. Yeah.
So thank you, sir. Thank you very much. Thank you, Dr. Lakkumar, for that wonderful talk, which was more practical. And we know that it is done, but we do not do it in a large
Yeah.
scale as you have been doing. We know that there are areas where we can do it. But having said that, probably, as you told, it is a thing that we should take it forward rather than even the monitoring the patient and looking at the severity, all those things, and even the need for admission and differentiating it from the other similar viral infections. So, Dr. Lakumar, it was a wonderful listening to you, and it was a great talk. Thank you so much for, accepting our invitation, joining us, and giving us the academic feast. Thank you so much. And thanks, Dr. Vijay Vele. Anytime you are told no to any academic
No,
event,
no, no,
thank you so
yes.
much.
Thank you.
And especially when Lakumar was to come, I just couldn't say no.
Yeah. That's what I
Yeah,
thought.
yeah,
When Lakumar is there, the best person would be
yeah,
Vijay Vele.
yeah.
So there are so
Okay,
many
thank you so much.
compliments from in the YouTube also that this was a really eye-opener talk. And I must say,
Yeah.
this is really eye-opener. So many things are something very new to maybe many. So definitely this will be looked at again and again on
Yeah.
YouTube for a long period of time. Thank you so much, Dr. Lakkumar,
Thank
Dr.
you.
Vijay, sir, and all the panelists who have joined. Thank you so much, all the friends, for joining. We'll continue our journey of International Speaker Forum in future months also. Thank you so much.
Yes. Thank you so
Thank
much.
you. Thank you.
Have a good
Bye-bye.
day.
Good day.
Bye.
Thank you. Thank you.